I'd like to let you know that Aussie Med Ed is sponsored by Heidi Health, who provide Heidi AI transcription platform. The team at Heidi have told me that Heidi is the AI scribe built in Australia and trusted in nearly 2 million consults every week. The Heidi team have told me that students and trainees get free access to Heidi Pro, which they believe will aid quicker, smarter notes, allowing more time for patients, learning and rest. To learn more about the Pro account, visit heidihealth.com/pod. The cornerstone of the human body is the human foot and ankle. They're remarkable structures with 26 bones, 33 joints, and more than 100 muscles, tendons and ligaments working in perfect harmony to support our weight, balance and movement. Yet they're often taken for granted until something goes wrong. Whether it's a simple sprain, a stubborn bunion, chronic heel pain, or even end-stage arthritis, problems in the foot and ankle can profoundly affect mobility and quality of life. In today's episode, we'll explore this fascinating region, what GPs and medical students should look out for in everyday presentations, how to assess and investigate common conditions, when referral to a specialist is appropriate, and what modern surgical options, including total ankle replacement, can offer. Joining me to unpack all of this is Dr Peter Stavrou, an orthopaedic surgeon who specialises exclusively in knee, foot and ankle surgery. Together, we'll discuss how advances in technology, implant design, and minimally invasive approaches are reshaping the way we treat these vital joints, and more importantly, how we can help our patients stay mobile, active and pain-free. G'day and welcome to Aussie Med Ed, the Aussie-style medical podcast, a pragmatic and relaxed medical podcast designed for medical students and general practitioners, where we explore relevant and practical medical topics with expert specialists. Hosted by myself, Gavin Nimon, an orthopaedic surgeon, this podcast provides insightful discussions to enhance your clinical knowledge without unnecessary jargon. I'd like to start the podcast by acknowledging the Kaurna people as the traditional custodians of the land on which this podcast is produced. I'd like to pay my respects to elders both past, present and emerging, and recognising their ongoing connection to land, waters and culture. I'd like to remind you that all the information presented today is just one opinion, and there are numerous ways of treating all medical conditions. It's just general advice and may vary depending upon the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition, and you should always seek the advice from your health professionals in the area in which you live. Also, if you have any concerns about the information raised today, please speak to your GP or seek assistance from health organisations such as Lifeline in Australia. Well, today I'm joined by Dr Peter Stavrou, an orthopaedic surgeon based in Adelaide, South Australia. He specialises exclusively in knee, foot and ankle conditions and is past president of the Australian Orthopaedic Foot and Ankle Society. And he has over 20 years of experience in this subspecialty. Since 2003, Dr Stavrou has dedicated his practice to the management of foot and ankle disorders, ranging from arthritis and deformity to sports injuries and complex reconstruction. He has a particular interest in minimally invasive keyhole bunion surgery, patient-specific joint replacement, and the treatment of ankle arthritis, including total ankle replacement. He is actively involved in the training of the next generation of orthopaedic surgeons as a principal supervisor of a foot and ankle fellowship program, and he contributes to the National Joint Replacement and Audit through his role as clinical advisor on ankle replacements to the Australian Orthopaedic Association National Joint Replacement Registry. It's a real pleasure to welcome Peter Stavrou to Aussie Med Ed to talk about foot and ankle conditions, from everyday cases in the GP clinic to advanced procedures like total ankle replacement. Welcome, Peter. Thank you very much for coming on board.
Hi, Gavin. Thanks for having me, mate. It's a real pleasure to be here, and we'll cover lots of ground today, so hopefully it'll be very informative for everyone.
Excellent. Well, look, I thought we'd start off with this basic, simple question. From your perspective, what are the more common ankle problems that medical students and junior doctors need to be aware of or they might encounter in primary care or in the emergency department?
Well, trauma is common. So for those in the ED, it might be a slightly different type. You can have high energy trauma, car accidents, falls, that sort of stuff. So here, making the diagnosis is the key, and then usually referral, because these sorts of things will often require surgery. But in other settings, in the ED or in general practice, trauma can also be low energy, and that can be things like sprains, undisplaced fractures. So this isn't so clear cut sometimes. The diagnosis may be a little bit tricky in terms of which investigation to use, and sometimes even something that appears to be a fairly trivial mechanism of injury or trivial injury can have significant pathology with it that you really need to be aware of and not miss.
I like to try and think of trauma as fractures, dislocations, infections, and obviously when the foot and ankle conditions, it might be tendons or nerve conditions too. When you see a patient with an acute ankle injury, what's the key history and examination aspects that you use to help divide up your specific traumatic conditions that you see?
Yeah, well, I think the mechanism of injury is important. That will help you define, hopefully, whether this is a high or low energy injury. Simple things like, could they walk after the injury straight away? Or if they were playing sport, Could they play on? Could they finish the game? Or did they have to come off the field? So things like that give you an indication of the sort of significance of the injury to some degree. Examination in the acute setting can be really quite difficult. People are sore, they're very swollen, so sometimes your landmarks may not be obvious due to the swelling, and it may be very hard to localise where exactly they're sore because the whole foot and ankle hurts. So that is really difficult, and even the pain may be difficult to put a finger on. It just hurts everywhere. So I think that's the tricky bit in acute trauma, is trying to narrow it down to a particular injury. So the mechanism and the history can help you there, where examination may not be so easy.
Yeah, we always think about the Ottawa rules. Are they actually useful in practice, and do you use them at all?
Oh, look, I think they're a guide. Like everything, they're a guide. They're not set in stone, but they are, because the reason they exist is to avoid unnecessary x-rays and the radiation penalty that goes with that for patients. So really, to explain the Ottawa rules, if you're unable to walk 4 steps either after your injury or when you're seeing the doctor in the emergency room, that's indicates some sort of significant injury. If you have pain around the malleoli, medial lateral malleolus, and also if you have pain up the posterior border of either the fibula or the medial tibia for 6 centimetres above the joint, that's an indication that there may be a significant injury, and it's probably worth doing an x-ray. If you don't have those things, it's most likely a sprain, and you probably don't need an acute x-ray. There are also some foot rules for Ottawa that have been expanded. So if you have pain at the base of the 5th metatarsal over the navicular, or if you can't walk 4 steps with a foot injury, that's another reason to do an x-ray. But if you don't have any of these things, the yield of finding a fracture on an x-ray is less than 1%, so it's probably not worth the effort.
Excellent. What are the common red flags in ankle trauma then that signal the injury might be even more than just a simple sprain? Is it just purely the Ottawa rules, or are there other things too that you need to think about?
Oh, look, I think the history and the energy involved in the injury. So someone who's in a car accident, high velocity, a fall from height, and obviously the signs, a lot of swelling, that indicate there's a significant amount of trauma there. Other things you need to be wary of so that you don't think, oh, this is just a sprain, and send someone off.
So Peter, if an ankle injury or an ankle sprain just isn't improving after 2 to 3 weeks, what conditions should we be thinking about? For example, do you need to think about osteochondral lesions, peroneal tendon lesions, or even just stress fractures? What are the things you sort of go through your mind that are just more than just a simple basic injuries that the students might be aware of?
Yeah, all those things are possible, and the reality is a really bad ankle sprain may take up to 3 months to fully recover in terms of someone being really comfortable and returning to sport with comfort. So at 2 or 3 weeks, a lot of people will still be quite sore, but I think the key is if they're not improving at 2 or 3 weeks, then your mind should be thinking there's something maybe more significant here than just a regular ankle sprain, because even if they're sore at 2 or 3 weeks, they should be getting better. So the things to really consider, as you say, a chondral injury, so some sort of damage to the cartilage in the ankle joint, and that may not be obvious on an x-ray if you've taken one. Syndesmosis injuries, and we'll talk about that later, they're a specific type of ligament injury. Peroneal tendon injuries, again, you said that, so that's very important. Fracture of the base of the 5th metatarsal. So that's one that is near the ankle, and it may get caught up when you initially see someone in all that swelling and not be noticed. And it's often one that is right on the corner of an x-ray as well. So when you look at the ankle on the x-ray, you may look back and see there's a little fracture there that you haven't quite appreciated at the time. So that's always a tricky one. The anterior process of the calcaneus, that's even closer to the ankle joint. And it is really hard to see on an x-ray because of the shape of the bones and the overlying bones. So that's one that's, again, commonly may not be appreciated immediately. And then obviously the Lisfranc injury, so that's in the foot. But again, everything may be swollen. It may be hard to localise that, and you have to consider that as well. So I think if you're not sure, by 2 or 3 weeks, if the patient's coming back and they've still got a lot of pain and they're not really getting better, take the opportunity to re-examine them at that point. Hopefully by then their swelling subsided, they're not as painful everywhere, so you may be able to localise the area of pathologies and you'll be able to pick the landmarks up. So those are the sort of things that you can do at 2 or 3 weeks, and it's just not going to be as uncomfortable for the patient at 2 or 3 weeks to examine them again. So don't be shy of examining the patient again if they come back after 2 or 3 weeks. And the other thing you can do is, if you're concerned, you can re-x-ray them. And some of these injuries are ligamentous injuries, so they won't show up on x-ray as a fracture, but the ligamentous instability will if you x-ray them weight-bearing. And sometimes you have to wait for a period of time, 10 days, maybe 2 weeks, for the patient to be able to do that comfortably. So that's a tricky thing as well. So don't be shy in re-examining the patient and talking to them again and seeing if you can get a different perspective than initially. So
if it's not selling after 2 or 3 weeks, you're re-examining them, what would be your sort of protocol? Would you do weight-bearing x-rays first, and then, depending on where there's tender, further on investigate, or how would you proceed at that stage?
Oh, exactly right, yeah. So I think if you can narrow it down to the ankle or the foot, then you get the appropriate x-rays, And again, you may see a fracture then that you didn't see initially, or you may even see just a periosteal response, so the bone trying to heal rather than the actual injury. But if there are ligamentous injuries, then you may see widening either in the midfoot or around the ankle. And if you're at that point, then you need to further investigate. So we'll talk later about different tests you can do. But I think it's always worth looking back at re-examining and re-investigating if there are still concerns that someone is really struggling at 2 or 3 weeks where you think they shouldn't be given the injury they've had.
So would you non-weight bear them in that time, or would you put them in a special boot to protect them?
It really depends upon their symptoms. If someone's unable to walk, I think it's very sensible to put them in a boot. It will allow them to rest. It'll force them to elevate their foot, which will help with swelling, because obviously in the foot and ankle, as long as your foot's below your heart, it will swell. So it'll allow them to swell. It'll also hopefully make them comfortable enough to weight bear rather than be stuck on crutches for a couple of weeks. But some people will still not be able to do that even with a boot. So I think it's quite reasonable and sensible to use a boot. If someone can walk but not very well, then they might get away with some crutches and just assisting them in weight bearing. But if they're really in trouble, then a boot I think is very sensible. If there is a fracture there, then you've already instituted the treatment for the fracture, even if you didn't know it was there yet until you re-examine them in a couple of weeks.
So Peter, if I just think about this in a bit of specifics, obviously someone comes in, they've had a significant trauma. If they fulfil the criteria of Ottawa rules, you'd x-ray, but if they're normal, you still just protect them or at least re-observe them 2 weeks later. If they don't fulfil the rules of Ottawa and therefore you're thinking it's more of a soft tissue injury, again, you're going to just treat it as a sprain. But 2 to 3 weeks later, they come back. If they're still tender over the soft tissues and you're thinking it's still more of an ankle sprain and you've re-x-rayed and it's still no fracture, would you proceed to an ultrasound to assess the ligaments at that stage, or would you still continue down the ankle sprain pathway?
Oh, look, I think it would depend upon how sore they are, and I think they're both reasonable paths to take. Ultimately, if the ligaments are injured, in most people, they're going to go down the rehab pathway regardless. So it may not be necessary to know that the ligaments are injured, because the treatment, certainly referring them off to physiotherapy for physio-guided rehab, maybe a brace, those things, you would do regardless. The algorithm in terms of whether they need an operation or not really would depend upon if they failed that rehab treatment. So I think I'd treat them symptomatically. If they're really bad, they'd be in a boot. If they're not, maybe a brace. And then once they're comfortable enough, and that's the tricky bit, to institute physiotherapy. There's no point going to the physio if you're really sore. All you're going to do is get tortured at that point and no one wins. So they need to wait long enough to be comfortable to start their physio rehab is the key thing. And if they need a boot or crutches or a brace in that time, I think I treat them symptomatically. But the aim is that they should be getting better so that they need less and less of that and they can have their physio.
Sort of a loaded question, I ask you that, because sometimes you see junior doctors showing me a set of ultrasounds showing complete tear of the anterior talofibula and a complete tear of the calcaneofibular ligament, and they think it's something that needs urgent surgery. In that scenario, what do you say to the junior doctor who comes with an ultrasound showing them that? How do you reassure them?
Oh, look, I think ultimately you're treating the patient, not the X-ray or the ultrasound. And this is an injury we've been doing for a long time, for many thousands of years. And we managed to get through most of that without people like me operating on them. So I would say, look, this is a significant ankle sprain, but that doesn't mean, in most people, that doesn't mean you need an operation. So the ability of the ligament to heal and with good rehab to end up with a stable ankle is quite high from here. So I think 90% plus of people with a really bad ankle sprain still won't need surgery. It's the ones who have recurrent instability after their rehab that will. So whilst that's concerning, I would still go down the same path. I don't think there's a place, even in the elite athlete, for an acute ankle sprain, a sprain like that, to be operated on immediately. I think rehab would be the first goal and try and rehab that and recover that as it is. And it's not just the junior doctors that do that. The patients often come with their ultrasound and they've read it and they're very stressed and saying, oh, what are we going to do about this? And you just reassure them, say this is very common, it's a very bad ankle sprain, but in most people it doesn't require surgery. And they're actually quite relieved. They go from being very stressed about this finding on an ultrasound to realising that they probably won't need an operation and they'll be fine just with some physio and a bit of time, which most of us aren't very patient. So got to reassure them it will get better.
Yeah, reinforces what I told a medical student the other day, that one of the best forms of pain relief is actually giving the patient education, and that can help reassure them and let them get through that acute episode.
Exactly, I couldn't agree more. I think patients, that they all go on the internet and look at Dr. Google, and there's some great stuff on the internet and there's stuff that's not particularly accurate. So I think if you, as an expert, if you say to them, look, I think you'll be fine here, it'll take a bit of time and you probably won't need an operation, most of them are reassured by that.
If we're going down that same pathway of thinking about how we investigate them, Let's say at 2 to 3 weeks we do the x-ray because they're still sore and there's nothing particular on that, but they're actually either tender on a squeeze test between the tibia and fibula, and you're wondering maybe it's a syndesmosis, the ligaments that join the tibia and fibula down by the ankle joint, or they're tendered right down near the subtalar or the ankle joint themselves, and you're thinking maybe it's one of these anterior processes, the calcaneus. What's the next form of investigation? You're not going down the path of an ultrasound looking for a sprain, you're thinking of one of these other structures. How would you investigate then?
Well, I'll start with the syndesmosis injury because that is a significant injury, and it's probably one that is more likely to need surgery than a regular ankle sprain. To start with, in terms of considering that, the history is slightly different, the mechanism is different. Your regular ankle sprain is inversion plantarflexion, the foot is forced down, you roll your ankle. With syndesmosis injuries, it's the opposite, it's dorsiflexion and eversion, so the foot's turned out or the foot is stuck on the ground and you're twisting away from it, sort of thing, which we often see I see that in footy players where they're in a pack and someone stomps on their foot and they get bumped on a trapped foot. So the mechanism is different. In terms of investigating it, you need to know whether the injury is stable or unstable. So in terms of diagnosing the injury, an MRI is quite good. It'll show you whether the ligaments are intact or not. It'll also show you any other associated injuries because that may not be an isolated injury. You may have a deltoid injury as well on the other side of the ankle. But ultimately, to work out whether it's stable, you can do a weight-bearing x-ray. Now, people's anatomy isn't identical. And so I think if you're concerned, you would do an x-ray of the other side and see if they're the same. If there is widening of one compared to the other, then obviously that's an unstable injury and you should do something about it. The other tool we have available is a weight-bearing CT scan. And that's a great instrument. And what you do is you scan both feet as weight-bearing, as I said. And what you're looking for is a difference between the weight-bearing scan and the non-weight-bearing scan on the same foot to see if there's a difference in the distance between the bones or between the weight-bearing one side and the other side. And again, there are some parameters, but if there is a significant difference, again, that's indicative of a significant instability, and that should probably be treated surgically. So even if the ligaments are intact, you can have that. And I guess the grey area is when there is, say, an MRI or an ultrasound damage to the ligaments. Usually it's the anterior syndesmotic ligament, but that doesn't necessarily mean that the joint is unstable. So if you've got x-rays or weight-bearing CT that show no widening, I'd be happy to treat that non-operatively even if the anterior ligament is damaged. And also, it's a similar situation for Lisfranc injuries in the midfoot. The weight-bearing CT is very good there, as is a weight-bearing x-ray. And again, you need to wait 10 days, maybe 2 weeks for the patient to be comfortable enough to do it with a fair amount of force through their foot to show that significant difference in widening. And same thing, if there is a big difference either between one side and the other, or the same foot weight-bearing and non-weight-bearing, then you probably should be doing something about that. So that's how I treat it. In terms of the other injury you talked about, the anterior process fracture of the calcaneus, if you're suspecting it, probably an MRI is the best bet. Because the great thing about MRI is it will show you the bones, the ligaments, the tendons, all the different things, the cartilage, all the different things that can cause pain in one image. Other imaging modalities have strengths, but they also have weaknesses. MRI is pretty good. So that's where I'd go with that if I was worried about that side of things.
And I think just for the syndesmosis injury, the reason it occurs more when it's in dorsiflexion is because the talus is wider when it goes into dorsiflexion.
Yeah, it's also the rotation. It's like a wedge, and as it rotates around, it pushes the fibula. It opens it up. It opens it up like a door. If you're looking at it, the ankle from the front, the fibula gets rotated out and it opens like a door from the front. And if it's significant, it will tear the ligaments all the way from the front to the back. And that's obviously unstable. The tricky one is where you tear the front one or partially tear the front one and the back is intact. And that's where that grey area where you need to work out, is this stable, is it not? If it's stable, then probably a boot and some non-weight bearing and they'll be fine. If it's unstable, I think you need to fix it, because if those ligaments are unstable, every time you walk, your tibia and your fibula are being pushed apart because the distance is not constant. That has a very high risk of damaging the ankle cartilage. So long-term problems can be significant in terms of people not being able to play sport or even leading on to arthritis.
Yeah. And both Lisfranc's and syndesmosis are in dorsiflexion as the most common cause?
Generally they are. I mean, the Lisfranc injury, again, can be the same thing I was talking about in the football player. I've had a few who have been stomped on and then bumped, so their forefoot is stuck to the ground and the whole body pivots on it. So that sort of thing. Occasionally you get someone who falls, maybe misses a step going down some stairs and their foot gets folded under them. So there's forced plantarflexion with their whole body weight on top of it. Those ligaments are very strong, as are the syndesmotic ligaments. You require quite a bit of force to damage them. And sometimes it's because you're going at high speed, but sometimes it's just because your body weight, or if you're playing sport, 2 times body weight, someone else tackles you and lands on top of you, and those ligaments are damaged by 2 people's weight on top of the foot in an odd position.
I was smiling because both mechanisms will be classically caused when you're in the foot straps of a windsurfer and thrown off a windsurfer, for those who would know what a windsurfer is. I use this as an excuse as why I never got on the foot straps, but really it's because I'm a pretty average windsurfer.
Yeah, look, and again, classically, the Lisfranc injury was described in cavalry soldiers who were thrown off their horse and their leg was stuck in the stirrup. But I guess the windsurfer is a modern form of that. And obviously the contact sport with people at close quarters getting bumped and is a similar sort of injury. It's the same mechanism. It's just the velocity is different. But ultimately, if someone's got a bad injury, it can be significant in terms of returning to sport, or long-term in terms of just walking comfortably.
And the Lisfranc injuries are the injuries of the tarso-metatarsal joints, 2nd, 3rd and 4th predominantly?
Generally, because of the number of bones there's a lot of different types, but it is through that joint. So sometimes you can have the first, or between the first and second. Often it's usually around the second, the base of the second, the base of the first. Sometimes it can extend even more proximally, so it can come between the cuneiform bones. So it just sort of goes vertically through and splits the whole sort of first ray off. So you have to fix even a bit further back when you do surgery. But if you're suspicious of it, I think if they're really sore, the other thing you classically see, which I didn't appreciate till I was well into my training, is you can see some bruising. If you see bruising on the arch of someone's foot, bleeding and bruising, that's almost pathognomonic of a Lisfranc injury. So if you see someone who turns up with an ankle sprain, or they've twisted their foot and they have this bruising in the arch, you should be suspicious of it and probably investigate for it, or at least think about it seriously.
So that's on the medial arch. I suppose on the lateral ray at the base of the 5th metatarsal, you'd be thinking more of a base of 5th metatarsal or Jones fracture. I always get the two mixed up. What are the different types of 5th metatarsal fractures you can get?
Well, the Jones, it's a term that people use to lump them all together, and you can get some that are just at the tubercle, which is the very base of the metatarsal, right at the end of it, and further down. Jones fracture is notorious for non-union. That's the big thing that people worry about, is that it won't unite. Even then, probably 90% of them do. If you're seeing a young, fit person, having a 10% non-union rate is very high, because almost all fractures will heal in a young, fit person. So even 10% is still very high. And it's a twisting injury often. It can be missed as part of an ankle injury. Sometimes it can be a stress fracture that will then complete. So someone will do something and they hear a bit of a crack, they can't play on. But when you look at it, this is not an acute injury. There's an old fracture that they've completed. In that case, it may actually heal the fracture, because you've stimulated a lot of healing for something that wasn't healing that well. If you've got certain types of foot shape, that can be more common. So if you've got a very high arch, because you're putting more weight on your 5th metatarsal, that can lead to a fracture as well. But again, it's just being wary of it and knowing that it may not heal. But even though it's notorious for non-union, 90% of them will still heal. And that's a pretty good outcome. But just, be aware of it. And if there's any concerns, refer it on for someone to have a look at, and it may require surgery depending on the patient and their circumstance.
Now, these are just a few of the fractures, but how common are these syndesmosis injuries or the Lisfranc injuries compared to a standard ankle sprain or an ankle fracture?
Oh, look, ankle sprains are incredibly common. I think it may well be the most sprained joint in the body. And in terms of ankle fractures, they are still the commonest lower limb fracture. So even though these things are important, they are a small percentage compared to ankle fractures. So the commonest thing you'll see is an ankle sprain. The commonest fracture you'll see in this area is an ankle fracture. A regular ankle fracture, which will either be undisplaced and just require either a boot or a plaster, or probably a boot more likely nowadays, or something that has some displacement that might require surgery. But that's the bread and butter. All these other things are much less common, but you just need to be wary of them, because missing them can have quite significant outcomes for the patient long term. It's not just that it's dragged on for longer, that there may be damage to joints, which is hard to recover from.
Excellent. Well, if we move on to other injuries around the foot and ankle, one of the other ones that we hear about are the Achilles tendon ruptures. First of all, how do you diagnose them? You walk us through the squeeze test, the Thompson's test, and basically the pitfalls and diagnosis of them, and how the management's evolved from surgical to non-surgical to surgical. Well, I get confused.
Oh, look, yeah, and they are relatively common. The history, again, is of an acute injury. There's not often any precedent. Someone's just doing some sport and they hear a pop. They will often look around, they think someone's kicked them in the back of the heel, or if they're playing something like basketball, someone's thrown a ball at them and hit them in the back of the heel, and then they usually fall over because their Achilles isn't working. So that's the history. Most often the middle-aged male, the weekend warrior sort of thing, and I see quite a few who say, oh look, just playing social sport, they were short and they gave me a ring and I turned up and thing went pop. So that's often a common history, but it can happen in all age groups. So in terms of the diagnosis, once you've got the history, the diagnosis is principally clinical. So the patient is placed face down on the bed with the feet hanging over the edge of it, and the calf squeeze test or the Thompson's test or the Simmons test, depends on which side of the Atlantic you're on. I call it the calf squeeze test, and then there's no confusion at all. You squeeze in the calf, and what you should see is that the foot plantar flexes. Other thing, obviously, if you run your finger down the back of the calf, you'll often feel a step or a gap in the tendon, so that's a giveaway as well. And I think that's the key. If you investigate them with ultrasounds, or generally with ultrasound, because that's very easily accessible, the one to be wary of is the partial tear, where they report it as a partial tear. And that's really tricky because a partial tear may be 30% or 40%, may also be 95%. So they don't often quantify how much. So if a partial tear may be something that isn't such a big thing, it may be a significant thing. So I will go on the clinical diagnosis. If I'm convinced that's what it is, I may investigate them with an ultrasound or an MRI if I'm concerned about something else or where it is, because sometimes it can be a lot higher than the usual spot. It's usually about 5 to 7 centimetres above the back of the heel, where the Achilles joins the calcaneus. But if they're higher up, they can be at the musculotendinous junction where the calf muscle becomes tendon. That's harder to repair because you're not repairing two tendons if you're considering surgery. So that's the diagnosis. In terms of the treatment, when we were young men, the treatment was either surgery or not surgery, and non-surgical treatment was put him in a plaster for 8 weeks and then say, oh, you'll be right, off you go. And really now there are almost 3 different arms of treatment. There is non-operative, which is usually in a boot. There is functional treatment, and then there is surgery. And the functional side is very protocol driven, where you put them in a splint almost immediately within 24 hours of the injury, and then you can start them going with very specified physio under observation. And whilst that has some good results, it really requires almost like a bigger system where physios are integrated in the system. So in places like Canada or the UK, they will often do that because they're all working within a hospital. But in our system where you may not have any contact with the physio at all, it's very hard to make sure we're all on the same page. So whilst that has some results, I'm not sure it's as effective in our system where the physio may not be known to the doctor and you don't have a common protocol you're driving on. So for me, I will talk to the patient about the treatment and the pros and cons, and it depends on the patient. Non-operative treatment still has good outcomes. You're talking about 85, 90% won't have any problem. And the big problem if you have one is rupturing the tendon again. Where the tendon heals is a weak point, it's potentially a rupture point again. If that happens, it will usually happen within the first year after the initial injury. So for non-operative treatment, for me, you're in a boot for 8 weeks, and I'll use some heel wedges in the boot. So they'll have 3 heel wedges in the boot. Every 2 weeks, I take out a wedge. So they start with 3 wedges, 2 wedges, 1 wedge, no wedge. That's their 8 weeks in the boot. At 2 weeks, they're usually comfortable enough to start walking. So I let them walk at 2 weeks in the boot. So that's my non-operative protocol. So you're not stuck on crutches for the whole 8 weeks. You can walk, but you just got to stay in the boot. The other thing to be wary of if someone is treated non-operatively is DVT. Even though we're not having an operation, the calf muscle, all those calf veins in the muscle, it's not just that they're immobile because you're in a boot. You've actually damaged them as part of the injury. You're actually damaging the calf muscle and that whole mechanism. So I usually put people on aspirin. I'm not sure you need to do anything more than that. If there are risk factors, then you may need to use something else, whether Clexane or one of the oral anticoagulants. But just be wary of DVT risk because you're damaging the muscle where those calf veins are as well as immobilisation. So that's something we don't often think about when we're treating someone non-operatively. And with an ankle fracture, I probably wouldn't think too hard about it, but with this one, it's maybe something to consider. In terms of the surgery, what are the pluses of surgery? Look, the re-rupture rate is probably lower. It's probably 3 to 5%. So that's a lower rate. So you're talking about a risk of having no problems goes from 85 to 90% if you don't have an operation to maybe 95 to 97% if you do. So it's still not a massive difference. So lower re-rupture risk. The amount of power and strength you lose after your injury might be a bit lower, but it's not that big a difference that you'd say you have to have surgery. And that's the tricky bit. There is a lot of grey here. There's not a right and a wrong way to do it. I talk to the patient, give them the pros and cons, and then let them decide. That's the key thing. But the treatment is much the same. Boot for 8 weeks, wedges, take out wedge every 2 weeks. I let them walk after 2 weeks once the wound is healed. And then at 8 weeks, then when they come out the boot, then you start the physio. Right? And it's really just those basic things, range of motion, some strength, and then some balance type stuff. With regards to return to sport or activities, at 6 months, I'm happy for people to return to some sort of modified training if they're playing sport, but I'd want them to be in a position where they're not having to push themselves and push off and do things. At 9 months, 9 to 12 months is when you can return to full training and competition. And that timeline is the same for whether you have surgery or not, really. That's the sort of goals I tell people after this.
Is that a slower recovery for an Achilles tendon rupture than for, say, someone with an ankle break? Or do ankle fractures also take a fair bit of time to recover? And what about syndesmosis injuries as well?
Again, some are quicker than others, but I think if you're in a boot for 6 weeks, things get very stiff and sore, even if it's a very small and minor injury. So I would think 3 months would be the absolute bare minimum for return to sport, but probably somewhere between 3 and 6 reasonable. But yeah, some of the syndesmotic injuries, I've had people saying, you know what, it took me a year to fully feel really good about playing sport and not worry about it and that sort of thing. So whilst you may be able to go back to sport sooner, in terms of having that confidence to say, look, I'm fully recovered, even if it's maybe just a mental thing of not being scared of re-injuring it, it probably is best part of a year. I think that's quite a reasonable assumption to make.
I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, as well as HealthShare's Specialist Referrals Directory, a specialist and allied health directory helping GPs find the right specialist. Excellent. Well, we've touched a bit on the traumatic sort of scenarios. I presume all your work's not purely traumatic. What's your sort of mix between traumatic and elective conditions in your practice? And what would be the average foot and ankle surgeons?
Most of my practice is elective. I don't do that much trauma nowadays. I think for others there may be a greater mix of trauma, but mine is mainly elective. And I do all foot and ankle conditions. So I'll do forefoot, which is bunions and arthritis and Morton's neuromas and things like that. And also some sports injuries. So again, the ankle sprains, arthroscopy, ligament reconstruction, tendonitis, are these sort of overuse type injuries, and obviously arthritis and deformity. So I might have a special interest in ankle arthritis and ankle joint replacement, but also the deformity of the flat foot and those sorts of things, which can be combined with arthritis. So sometimes they're not separate things. It's deformity with arthritis, which can complicate the picture. I also do some research, and I'm actually, with my interest in joint replacement, I'm the clinical advisor to the National Joint Registry on joint replacement. So that fills a bit of extra time if I had any.
Excellent. Well, we did do a episode on the National Joint Replacement Registry with Richard Page from an upper limb perspective, but they covered most of the registry in general. It was actually a very interesting talks. For those who are actually watching, they can listen to that as well. But moving on to basically assessment of a foot and ankle for an elective scenario, what's your approach? Does it vary depending on how they present with like pain or the neurological type scenario or with loss of function? How do you approach your assessment of a foot and ankle, particularly for a medical student coming up to the OSCEs exams as well?
I'll look again, you go back to the basics. You look at the history, timelines, how long has it been going on for? Was there an obvious cause for it? Was there an injury of some sort or something in the history that would indicate an injury, an old fracture or something like that? That may give you a hint as to what's going on here. And just simple questions of function, because often what we're treating is pain and function. So you want to know about the patient's pain. Is it activity related? Are they getting rest pain? Are they getting woken up at night with pain at night time? What treatment have they had? Does pain relief work? Have they had physio? Anything else? Have they had braces, injections, all those sorts of things? That's the main thing. Are there any aggravating factors? And then, as I said, just functional things. How far can they walk? If they can walk, if they walk with others, it's a great question. If they walk with others, can they keep up? Because they can say, I can walk a kilometre, but if they walk with their partner, the partner will have to stop 10 times over that kilometre to make them to allow them to catch up. So things like that. Is it better whether they're in shoes or out of shoes? If they wear a brace, does that make it better? What are they like on uneven ground? That's quite a good indicator of how good your function is. If you can manage uneven ground, that's quite good. So those sorts of things. So questions about their pain and the character of their pain and aggravating factors and also their function. So they're the main things in the history. In terms of the examination, stand them up, watch them walk. In my setting, I call someone from the waiting room, so I already get a hint of what's going on by how quickly they can get out of the chair and how well they walk into my office. I've already got an idea of how much they're suffering. For the medical student perspective, they're usually lying on a bed, so you've got to remember to stand them up and watch them walk, have a good look at their feet when they're standing, because obviously the shape of your foot changes between lying down and standing. So what may look like a fairly normal foot without too much trouble when they stand up may become quite obvious. and have an issue. Get them to single heel raise. That's a very simple test of function. If you can stand on one leg and then lift your heel off the ground, you're doing all right. And compare side to side. I always start with the good side, so I get an idea and I've got an idea of what I'm asking them to do, and then get them to do the symptomatic side. And then onto your examination, palpation, feel for where they're sore, look at their range of motion, assess their power. Neurology, look for numbness or weakness, instability of their ankle. So these are all the things you look for when you're examining a patient. Again, even though I know more than a lot of people about foot and ankle, the examination is still the same. That's still the basics, and making sure you're not missing something. Try and be as thorough as you can with your history and examination would be the hint for medical students.
Right. When they're presenting with more of a pain condition, is that usually going to be more of a missed fracture or an arthritis or a tendonitis? If they present with loss of function, could it be arthritis, but could it be deformity that's causing it? And is deformity always associated with pain?
Not necessarily. I mean, sometimes someone will come along with a second or third toe that's problematic, and they've got a large bunion, and the big toe pushing across has caused the problem in the second and third toe, but the bunion itself doesn't hurt. And that's a conversation to have with the patient. We say, look, I need to operate on your bunion to straighten that, to make room for the other toes to be where they should be. But they say, my bunion doesn't hurt. So those sorts of things. So the bunion, deformity doesn't always equal pain, I guess, and especially those sorts of problems with bunions and what have you, it really is a problem in shoes. If you're walking barefoot, it's probably not a problem. It's really the issue of trying to squeeze your foot into a shoe that's narrower than your foot that causes the forefoot pain. So deformity, it is a bit of a chicken and the egg thing sometimes too in the hind foot. Do they get arthritis and then develop deformity because of the arthritis? Or do they have a deformity because of some weakness that then, because of the abnormal forces on the joint, causes arthritis? And sometimes it's hard to know the answer. You never work it out. Your job at that point is to say, well, I can only work with where we are now, what we can do forward, and give you options as to how to manage it. And as long as you appreciate that there is deformity and arthritis, and that you need to deal with both of those things rather than just try and treat one and end up with a different problem later on.
Well, the one that comes to mind is the acquired flat foot deformity, where people get increasing flat foot deformity secondary to tib post dysfunction. Is that a common scenario? It's one I learned a lot about when I was studying for my fellowship exam, but obviously as an upper limb surgeon, I don't see it anymore. How common is this?
It is reasonably common, yeah. You do see a lot of it. People talk about collapsing arches, and I guess as people get older, that does happen. The one to be aware of is when you see one arch that's collapsed, not a symmetrical flattening of the arches, is that one is pretty flat and the other one's pretty normal. That's the one you think, well, something's going on here. And the other question to ask, what I often ask people is, have your feet always looked like this, or has that changed over time? Because someone may have flat feet from a young person, and so their feet may look no different, but now one hurts and one doesn't, but they haven't changed the way they look. So you need to get a feel for the baseline. But certainly the adult acquired flat foot it is a problem, and it becomes a bigger problem as it progresses. It's often due to the failure of the tibialis posterior tendon, and that's the one that comes around the medial side of your ankle. So it's running just under the medial malleolus. It's the main one that helps hold up the arch of your foot. So when people have what's called a flexible flat foot, so kids with flat feet, it works. It just doesn't like working all the time. And when you ask someone to stand up on their tiptoes, the arch will reconstitute, but in a resting position, it can't be bothered working. So in an adult, when that fails, and it's an overuse condition, it's like in the shoulder rotator cuff problems. As you get older, they become more common. The tendon starts to wear. It doesn't work as well, and the arch then collapses. So you end up with someone who had a normal arch, has now got a resting position of a collapsed arch, and they will present with tenderness often over the tendon itself. So you get referred with someone with ankle pain or thinking maybe they have ankle arthritis, and it's actually the tendon itself that's sore, and the joints are all fine, but it's the tendon. As it progresses, because of the change of shape in the foot, the joints will then develop arthritis. So that's one of those situations of deformity causing arthritis. And if you treat it while it's still in the position where you just have deformity without arthritis, there are simple things, inserts, good shoes, pain relief, all those things. If you're having surgery, you can reconstruct the tendon and do what's called a tendon transfer, and that will recreate the arch of the foot and give you a more normal shaped foot. But if you've got arthritis as a consequence of that, then the only option really is to fuse the foot. So you're recreating the shape of the foot, but you can do that by stiffening the foot in a fusion rather than tightening up ligaments, transferring tendons, which will give you the same shape but not losing any movement. So it's a fairly common problem. And some people just say, look, I can live with it, that's fine. But in some people, it's very problematic in terms of their quality of life. And that's really, in foot and ankle surgery, we're dealing with quality of life issues. We're not life and death, we're not heart surgeons or brain surgeons. It really is about people being able to walk comfortably and do the things they enjoy doing without pain.
And obviously with the force going through the body, you've got greater risk of getting arthritis in lots of areas, from the great toe way up through the foot, the forefoot, the midfoot, the subtalar joint and the ankle joint. And I presume most of those areas have their own specific types of treatment. Is that correct?
Yeah, look, I think that surgically they do. In terms of the initial treatment, it's non-operative. Surgery is always a last resort. So the initial non-operative treatment is obviously make the diagnosis, try and support the arthritic area. So good, comfortable shoes, usually an orthotic, so an arch support orthotic, and that can just be an off-the-shelf one. It doesn't need to be often custom-made unless your foot's got quite an unusual shape. So good shoes, good orthotics, pain relief, anti-inflammatories, Panadol, osteo, these simple things. They're the main things, maybe modifying your activity. Having a sore foot doesn't mean you can't exercise or stay fit and well. It just means you sometimes need to be smarter about how you do it. And instead of walking a lot or trying or running, you might find that cycling or an exercise bike or pool work or gym or Pilates or yoga, these things can allow you to keep fit and well, but not have a sore foot. So and that's for all those arthritis conditions in the foot. In terms of specifics, if we start at the forefoot in the big toe, hallux rigidus, what you'll find is that the stiffer the sole of your shoe is, the happier you are. Because when you walk or when you walk barefoot, the more movement that happens in the joint, it becomes painful. For the ladies, obviously, if they wear a heel, that can become problematic because it puts a lot of stress through that joint. Same in the midfoot, that as the arch collapses, that puts a lot of pressure through those joints. So just something like a nice arch support will support the foot and relieve pain. And it's sometimes important to remember that you're supporting the foot. Sometimes patients will have an arch support where someone is trying to correct their foot shape and make a very flat foot into a normal looking foot, and that can be quite uncomfortable. So the support you're requiring is really supporting the foot to make it comfortable as opposed to trying to correct the shape of the foot to make it look like something you might put a photo in a book of, sort of thing. So from that point of view, and the midfoot, and then in the hind foot, again, good sensible shoes. Often they'll have what's called a rocker sole. So that means the sole of the shoe is curved. So a good walking shoe or running shoe will have a rocker in it. If you put it on a table, you can roll it back and forth because of the curve. In some shoes, you may need to build that up because obviously the more movement the sole of the shoe has, the less movement your ankle has to do or those other joints have to undertake. So a rocker-soled shoe, and you can buy those commercially. It's a bit hit and miss because if you've got one foot that's a problem, you don't usually need two rocker-soled shoes, and sometimes the curve can be quite a lot. And for an older patient, I've had a few say they felt like they were on a boat the whole time. They were rocking back and forth. And you can get a rocker sole added to your shoe. So some of these people who do shoe repairs, they can add one to the sole of your shoe. And if you only got one side, you just need one, and they may build the other one up flat. So you've got a rocker on one side, a flat on the other, you feel even, and your ankle's getting a bit of a rest. So that's sort of the simple things you can do. Correct deformity for the ankle or the hind foot, you can use a brace, as well as an orthotic for the arch. So these things will all help. The aim is to allow you to get around comfortably without pain. Once you go beyond that, then you're really talking about surgery. In terms of surgery, for everything apart from the ankle joint, the treatment is fusion. So we're very simplistic in that way. You can't really replace other joints in the foot. There have been some attempts in the big toe, but none of them have been particularly successful. So fusing all those other joints apart from the ankle joint is possible. And fusion's quite an emotive word. People hear fusion and they take a step back when I say that. And so you have to take some time to explain to people what does a fusion mean and what is the outcome of fusion. So fusion is basically an operation where you take away what's left of the damaged joint and glue the two bones together. That means that there's no movement, but in arthritis, movement equals pain. So you're going to lose whatever movement you have in the joint. You'll also lose the pain that goes with it. And in some people, they have very little movement to start with, so they're not really losing a lot of movement. So that's the fusion side of it. The aim of, say, an ankle fusion or a subtalar fusion or one of these things, or even all of them, is that someone walking on a flat surface in a reasonable shoe, someone looking at you shouldn't know that you've had that operation. Right? Patients think they're going to be like some sort of pirate with a peg leg when they're done with the fusion. And so you need to say, no, someone who doesn't know you shouldn't know you've had that operation. And then they go, oh, that's a lot better than I thought it would be. And then you can have a discussion on whether they want to go down that path or not. So for all those arthritis conditions in the foot, fusion is really the only option. In the ankle replacements are available. They do exist. They're much newer technology and we're still getting a handle on them. But from my work with the Joint Registry, they are a niche market. So So if you look in Australia at ankle replacement, last year, the report just came out on the 1st of October, and there were 729 ankle replacements done in Australia last year in 2024. There were about 80,000 knee replacements. So it's about 100 to 1 ankle replacements to knee replacements. So it is a very small niche market. The numbers are small. From my perspective, I do about 25 probably a year. I do maybe a slightly less number of ankle fusions. So I'm about half and half in terms of my practice. Others will do more fusions, or some people won't do ankle replacements at all. They'll just do fusions. So it's there, it's available. It's not an option for all people with ankle arthritis. So there are people who are more suitable than others, and that's part of the discussion as you have with any patient about any treatment, about what is the best treatment for them as opposed to what the Joint Registry says is a good treatment. So in terms of that, who's a good candidate for an ankle replacement? Ideally someone older, a bit more sedentary, often if they've got adjacent joint arthritis. So someone who's had a subtalar fusion or a hindfoot fusion, if you fuse the ankle joint, that makes them quite stiff. So if you keep movement in the ankle joint, then that makes a big difference in terms of their functionality. Also, contralateral disease. So if someone's had a fusion on one side, you'd ideally like to replace the other side, because if you've got two ankle fusions, you can't propel yourself. It's hard to get up out of a chair. It's hard to push off. It's like walking on stilts sort of thing. So if you can keep movement in one ankle, then that's a really good thing. So people like with rheumatoid arthritis, inflammatory arthritis, these sorts of things, who have lots of joints involved, not just their ankle joint, they're good candidates. In terms of fusion, who do I offer that to? If there's a lot of deformity, sometimes there's things you just can't overcome with a joint replacement. If there's any sorts of weakness, because you need a stable joint to have a good ankle replacement. Young labourers, people who are doing heavy work, they're going to wear out their ankle replacement, and they're probably better off with an ankle fusion. The arch enemy of the ankle replacement is the farmer. They are such hard workers, they can't help themselves, and so that's the one you worry about. If you've got a farmer with a bad ankle, you just worry that they're not going to be able to help themselves and stop working. They keep going and going because they've got such a good work ethic. So in terms of fusion, what's the plus? The plus is that once it's done, you've had one operation. If it's fused successfully, then your pain is gone. Potentially, the adjacent joints may develop arthritis down the track, because if you're stiffening up one joint, the others may work a bit harder. You don't see that often, but you certainly do see it. If you have an ankle replacement, like your native joint, it may also wear out. If you live long enough, you may wear it out. Then you have to have that redone. And whether that's possible, whether you need to fuse it, that's a tricky thing. So that's why the younger, heavier, more active labouring type patient, or someone on their feet a lot doing heavy work, is probably best suited with a fusion, because they know they won't have to come back and have a redo of their replacement. So that's where we're at. In terms of the results, if you look at the results of ankle replacement, at 10 years, about 13.5% of them will have come back to have their ankle replacement redone. All right, so if you compare that to knee replacements, it's about 4.5%. So it's not as good as knee replacements in terms of longevity yet, but when we look at the results, say even from 5 years ago, it was 16% at 10 years. So in the short space of 5 years, we've come down 3% in terms of eversion rate, and it's getting better every year. So the aim would be that if you have an ankle replacement, hopefully it'll see you out and you won't need to come back and have it redone.
Right. Excellent. I know I'm going to probably ask a loaded question this way, but what's your favourite investigation when someone comes along to you and you're worried about arthritis?
I think an X-ray. Go with the basics. It's a simple thing, a weight-bearing X-ray, you'll often see it, and that's all you need to do. Once you go beyond that, I think an MRI scan, if you're not sure, or if you're worried about other pathologies as well, is very good, because you can see the state of the cartilage, you can see other things. If you're not sure where it is, if you want to localise it, something like a bone scan is a very good test. It'll help you localise, especially in the midfoot, because there's lots of little joints there. If you're not sure where it is, that's quite a good test for doing that. And in terms of treatment, we talked about surgery for arthritis. I think a cortisone injection is a very good way of managing someone. It's not going to solve their arthritis, but it will buy time. So someone who's got midfoot arthritis, who may not necessarily want an operation or a fusion, then I think a cortisone injection is a very good way to go, but you need to make sure it's in the right spot. And if you're not sure which joint it's in, then something like a bone scan is a very good way to do that, especially if the X-ray is not conclusive. In terms of cortisone injections, I get them all done under ultrasound. That way you know that the injection's in the right spot, because the worst thing is if you put an injection in and then someone comes back and says, I'm no better, Does that mean they're no better, or does it mean that you didn't put it in the right spot? With ultrasound, you can be assured that it's in the right spot, and then the outcome is more obvious. I tell people that it will take 2 or 3 weeks for the cortisone to work. So I talk to them about a month after their injection. By then it's pretty clear whether it's made a difference. I also tell them to do their normal activities after the injection. If they take it easy for a month, they'll tell me they're better, but that's because they haven't done anything. So you've got to, again, get them to do their regular stuff and see if it's really made a difference in their quality of life is the key thing for ultrasound-guided injections. The other thing is there are other things that people are injecting as well now. There are biologics, there is viscosupplementation. So the biologics are things like PRP, which is where you take someone's blood, you put it in a centrifuge, you spin it down, and you take some healing factors and inject it in around a painful area to see if it can cause some healing. The evidence here isn't conclusive, so there's certainly plenty of things available, but it's not conclusive. If there is evidence that's conclusive, it's probably more so to do with things like tendinopathies rather than with arthritis. And I guess in the upper limb, things like tennis elbow and things like that, there is reasonably good evidence. So maybe with tendinitis or something, it's maybe better than arthritis. But so that's, again, something that's evolving and we're still getting the hang of it. But certainly it's something to think about in patients. The other thing you can inject is what's called viscosupplementation. And that's really synovial fluid, effectively, is what you're injecting into the joint. Again, most of the evidence here is in the knee. There's not very much in the foot and ankle. In the knee, there is some good evidence that shows that you gain some time. In the foot and ankle, not so much, just because the research hasn't been done. So again, it's something to consider, but ultimately you're probably going to end up having to do something more than that in the long run.
And what about one of my favourite foot and ankle arthritic operations is the colectomy for hallux rigidus. Is that still a good operation in the early stages?
I think it is. Ideally, you need to work out what you're treating. So the colectomy is really shaving the dorsal part of the metatarsal head. So just the top bit, often there's a spur there, and that's where they're tender when you push on top of the joint. And what happens is when you dorsiflex the toe bumps into that and you get some pain, and it's really an impingement type problem. So if that's your problem, then shaving off that spur and some of the metatarsal head will allow the toe to dorsiflex, so you might increase your range of motion as well, but not have the pain that goes with that. So, and in early disease, I think it's a good operation. The problem is that spur is there because there is some damage to the joint, so that damage may progress. So down the track, they may present again with arthritis in the joint, in which case the treatment there is a fusion. If at the time of surgery, there is a lot of joint damage, then, it's a bit of a dilemma because you suspect this isn't going to last very long. But again, you're buying time here. For some people, you'll cure them. If their problem is just that impingement, then you've solved it. In others, that may progress, so they may be back to have a fusion. But I think it's still a good operation. It preserves movement. So we talk about joint sparing procedures, and that's what we're talking about, something that will allow movement for people who want to run or do something like that. You can still run with a fusion, but it's probably not recommended.
Yeah, I like it because it's one of the few operations where you actually are debriding an arthritic joint with actually reasonable results in that setting. There's not many around the place that can do that, but it has got short-term reasonable results, I believe.
Oh, exactly. And again, the other one that I do, colectomy sometimes, is in the midfoot, so around the Lisfranc joints, so the tarsometatarsal joints. You'll often see people who have some arthritis here and spurs on the dorsum, but their problem is pain when they're wearing shoes, and it's often related to the lump being rubbed on by the upper of the shoe. And if you can work out that the pain is coming from the lump being rubbed on rather than the joint, you can go in and shave that off and make them very happy. And again, same sort of thing. You're getting rid of that impingement that's happening by the shoe, but if the joint's not arthritic, they'll be very happy with that outcome, even though they've still got an arthritic joint on an x-ray.
What are some of the common elective conditions that GPs should know apart from just arthritis? Are there other things you should be thinking about as well?
Oh, there's a ton of things. I try and divide them up by sort of their location as a simple thing, because the patient says, I've got pain around my ankle. So you think, what is it around the ankle that might be giving me trouble? So things like Achilles tendonitis, instability or sprains, the arthritis, obviously we talk about ankle arthritis and other hindfoot joints, deformity, so the flat foot or the high arch foot, which will have ankle deformity as well. The other thing you see fairly commonly is plantar fasciitis. So that's pain under the heel. And for that, you don't often operate on it. I do occasionally, but you see it fairly commonly, and the treatment is fairly straightforward in terms of good, comfortable shoes, more padding under the foot, stretching exercises, physiotherapy, pain relief. It will generally get better on its own, but it can take anywhere from, say, 6 months to 2 years to fully get better. And so you just need to warn people again, it's about educating people and saying, look, this will take time to get better. And sometimes it does, or most times it does, but sometimes it doesn't. And if that's the case, then there is an operation you can do. And it's a little keyhole operation where you divide part of the plantar fascia. That seems to take the tension off it and it helps settle things down. So you can treat it with surgery, but most often it's just time. So in terms of other areas in the midfoot, we talked about arthritis, we've talked about collapse, and the midfoot collapse can be due to arthritis, but often due to this adult-acquired flat foot. We've talked about that, how to manage that, shoes, inserts, pain relief, and then beyond that you can talk about surgery, depending on whether there's arthritis or not. In the forefoot, bunions are very common. They don't always need surgery, but they are common. They tend to run in families, so there's often a story of my mum or my grandma or my aunt had these horrible feet, and it's important to reassure patients they're not going to suddenly wake up with grandma's feet tomorrow. The progression of bunions is generally very slow and takes many years. And so I tell patients the best predictor of what will happen is what has happened. If your foot was normal a year ago and now it's got a big bunion, it's probably moving quickly. It will happen quickly from here. But generally there's a story of many years of a bunion gradually getting worse. It'll gradually get worse over many years. At any point along that progression, if you want to do something, there's an operation that can be done to fix it. But really the timing is entirely up to the patient. It's their call as to when they want to do it. So that's bunions, hallux rigidus we've talked about, so the arthritis in the big toe joint. Morton's neuroma and metatarsalgia are two other things that are very common. So they're in the lesser toes. The metatarsalgia is pain under the metatarsal heads, and Morton's neuroma is the thickening of the nerve between the metatarsal heads. So we're talking about two conditions that are millimetres apart and sometimes are really hard to tell apart. So it can be very tricky working out what's what. For me, a lot of it comes down to the history. The history is opposite really for both of these. If you've got a Morton's neuroma, the symptoms come on when your foot's being squeezed because the nerve is being squeezed. So when you wear shoes, it's sore. People say, look, I put my shoes on and maybe after half an hour, I take my shoes off, I rub my foot, it gets better. And the pain is usually in the toes. They can be described as electric shocks or numbness in the toes. For metatarsalgia, it's really a pressure point under the bone, the metatarsal head. So for those people, walking barefoot is terrible. Walking in a good, comfortable shoe is really quite good because there's lots of cushioning between the foot and the ground. For the ladies, again, when they wear a heel, that puts a lot of pressure on your metatarsal heads. So they will often complain about that high heels or any sort of a heel will really give them trouble. And the pain is under the ball of your foot rather than in the toes. So the histories are generally quite different, not always, and the two things can coexist. So in terms of what to do, again, good sensible shoes, lots of padding under there. In terms of an orthotic, this is somewhere where something a bit more customised will help. You can get what's called a metatarsal dome, and that's an elevation in the metatarsal, and it sits under the shaft of the metatarsal. So it's not where you saw under the ball of your foot, it's further back, and it uses the metatarsal as a lever really to elevate the far end of the metatarsal. It spreads the load more evenly across the front of the foot, and that can often relieve symptoms. So that's a simple way to do things. Beyond that, there really is surgery. If it's a Morton's neuroma, the treatment is to excise the neuroma. So you take out the thickened nerve, and then that will get rid of the pain, but you also end up with some numbness because you end up taking out the nerve that supplies a web space in the toe. But that's a lesser problem to have than the pain that people are often experiencing. For metatarsalgia, if a dome doesn't work, then you're really talking about surgery, which is to do an osteotomy, cut the bone and shorten it up so that you're spreading that load more evenly. So they're the sort of forefoot problems. And obviously you talked earlier about claw toes, lesser toe deformities. So claw toes, hammer toes, all those things. Again, simple things, a nice wide deep shoe. If you've got a shoe with lots of room, they're not going to rub. That'll solve the problem. You can solve these problems by either changing the shape of your shoe or the shape of your foot. And so if you want to get new shoes, that's fine. I often tell people you can either look good or feel good. It's hard to do both at the same time. But in terms of lesser toe deformities, surgery can be done. It usually involves fusing the joints in the toe so that you keep the toe stiff and straight so that it just makes it more comfortable. So yeah, there's lots of different things that you need to know about. Most of them can be managed fairly simply with shoes, maybe inserts, pain relief, activity modification. Once it goes beyond that, then there are obviously more complicated things such as surgery.
Excellent. Is it still narrow shoes part of the factors in causation, or is it all genetic?
Oh, look, I think it's a combination. I mean, if you've got a family history of bunions, I'm not sure what shoes you wear is going to make a difference. The narrow shoe is probably, in terms of the people I see, is more an aggravating factor. Whether it caused it or not is hard to know, but it certainly irritates the foot when they're wearing narrow shoes. And that's why they come and see me, because I've got pain now. So it probably is partly environmental, partly genetics, but ultimately, if you're wearing a nice wide shoe, it tends to be less of a problem. So I think there's not a simple answer to that question, but certainly narrow shoes will make it more symptomatic for the patient, who then, if they want to wear those shoes, will be possibly more likely to want to have surgery to change the shape of their foot to fit into that shoe. But if your shoe's narrower than your foot, you're going to have a bit of a problem regardless.
So we've covered a fair bit already, Pete, but one of the ones that I always struggle with when people ask me about injuries are stress fractures. I believe you get stress fractures in all parts of the lower limbs. What are the common ones that you see, and can you tell me a bit about them?
Yeah, look, stress fractures are overuse injuries, like tendonitis, like those sorts of things. So often in the history, when you're talking to patients, there's often been a change in activity, but that change may be 6 or 12 months ago. So it takes a long time for that to become symptomatic. So if someone they may have commenced a new activity, they may have taken up running or going to the gym, or if they're doing it already, they may have changed their routine, they may train more often, they may increase the intensity of their training, they may have changed their shoes or the surface they're running on. So sometimes there's a change, and it may not be recent, that is the precipitant for the stress fracture. So that's the first thing you want to see. You want to work out initial management, decrease activity till you become pain-free. So if you're getting pain with sport, then stop that particular type of sport till you're pain-free for a period of time, and then you can slowly increase what you're doing. If you're just getting pain, say with walking, then it may well be that you need a boot or even a period of non-weight bearing to become pain-free before you then go back to walking and then to training. In terms of your recovery, you need to have a stepwise progression in your recovery. So if you can't just suddenly go back to running 10 kilometres, you've got to build up to that after. So you need a period of being pain-free, maybe even 6 or 8 weeks, and then slowly increase what you're doing. Assistance from maybe one of the sports physicians or the physios is quite good. They can guide you through a program. They can measure things as well. So sometimes it's about, you may not feel like you're improving, but because they're measuring things, they can tell you that you are. If there are particular biomechanical issues, sometimes podiatry may help with orthotics. If you've got a high arch or something like that, may make you prone to stress fractures. That's the key thing. Sometimes when you're going back to activity, you might find that if you get really sore, you need to drop down to a previous level for a bit, become more comfortable, and then slowly increase again from there. The other thing that is really underappreciated in stress fractures is vitamin D deficiency. Right? I mean, even in young athletes, you do see it, and obviously in community, it's very common. If you test for it, it's very common. We think we live in Australia, how is that possible? But a lot of us live and work indoors a lot. We don't get a lot of sunlight. We're very conscious of skin cancer, so when we go out, we wear hats and long sleeves and sunscreen. So if you see someone with a stress fracture, think of vitamin D deficiency. That's a simple thing to treat for that as well.
What are the sites of stress fractures that you see?
Yeah, I mean, the base of fifth metatarsal, so that Jones fracture is one that you see. The second and third metatarsal is what's commonly called a March fracture. So that's someone who may have taken up running or a lot of walking. The stress through that, if you've got a high arch, that may be more common. Also, the navicular has a stress fracture as well. And you see that often in jumping athletes. So I see a few footy players who get it, like ruckmen and people like that who are doing jumping, or basketballers. The navicular, so that's further back in the foot. And every now and then I see someone with an older person with a calcaneal stress fracture, and that's due to osteoporosis. So they may present with something like plantar fasciitis with heel pain, and then you do an MRI and you see they've got a calcaneal stress fracture. So they're the commoner type of stress fractures. In the tibia and things like that, they're pretty uncommon. They do happen, but it's mainly fifth metatarsal, navicular, second and third metatarsal are the common stress fractures.
So the other thing I see a bit about are people who recurrently sprain their ankles, have got lax ligaments, or they've had a bad injury and they've got unstable ankles. Are they common, and how do you treat those?
They are common. Again, most people with one ankle sprain or two ankle sprains with good rehab won't have recurrence. And it's the people who have that recurrent injury who, when you talk to them, they say, I just can't trust my ankle. That's the sort of common story you get. They're the ones who you would consider surgery on. And again, it's working out what their problem is. It's the ligaments. If it's the ligaments laxity, if they've got weakness, it may be peroneal tendon injuries. Every time you roll your ankle, you may cause injury to the peroneal tendons. The other thing is that usually their ankle is not painful in between sprains. So day to day, they're not sore, but when they roll their ankle, obviously it hurts. If you've got someone who has pain day to day with an unstable ankle, you need to think about something going on in the joint, like cartilage damage or some chondral injury within the joint. So you need to investigate the joint because they may require that dealt with as well as their instability. The other thing you need to look at is any deformity. So some people have a varus hindfoot, so their heel is coming in, the heels come in towards each other when they stand. If you look at them from the back, that's going to put a lot of stress on all the lateral structures, so the peroneal tendons, the lateral ligaments, all those things. If that's the case, then often if I'm going to undertake surgery, I'll often do an osteotomy and realign the hindfoot so that you give whatever operation you do to the peroneal tendons or the ligaments has a much better chance biomechanically of succeeding. If you repair all the lateral structures and the foot still turns in, you're probably going to be back where you started from after not too long. So treating any deformity within the foot that may make them prone to rolling their ankle, treating any weakness such as peroneal tendon injuries, and then obviously treating the ligaments and any other cause of pain. And in terms of that, it's probably 5% or maybe 10% of ankle sprains that'll ever get to that point. But if they've had a good trial of proper management with physio and all those things and they're still not able to trust their ankle, I think it's a very reasonable and sensible thing to do. And timelines to return to sport, in my case, they're in a boot for 6 weeks. So at 3 months, they'll be getting there. They'll have had 6 weeks of rehab. But yeah, to really get back and say they're fully into it, it's probably best part of 6 months for them to be comfortable back at sport and confident that they can trust their ankle.
Well, Pete, we've covered a lot of ground today. We've covered everything from fractures and dislocations, sprains, through to arthritic conditions. I think you've really appreciated you coming on Aussie Med Ed and going through what are very common foot and ankle conditions, and you've said yourself are the most common fractures in the lower limbs. So, look, thank you very much for coming on Aussie Med Ed. It's great to have you here.
Thank you, Gavin. It's been a real pleasure and great to talk about some of these things. Hopefully someone's gained some value from it and some useful knowledge. Thanks, mate.
Thank you very much. Thanks a lot.
Cheers.
Well, that's been a fascinating discussion with Dr Peter Stavrou, giving us a valuable insight into one of the most intricate and essential parts of the body, the foot and ankle. We've explored how GPs can recognise early warning signs, manage common presentations, and understand when referrals are appropriate. We've also learned how surgical advances, including total ankle replacement, are improving patient outcomes and quality of life. As always, the key takeaway is collaboration between GPs, physiotherapists, podiatrists, and orthopaedic surgeons to ensure patients get the best possible care. If you'd like to find out more or catch previous episodes, visit medicalpodcast.au. And don't forget to follow us or subscribe to Aussie Med Ed wherever you get your podcasts. Thanks for listening. I'm Gavin Nimon, and I look forward to joining you again next time. Until then, please stay safe. I'd like to let you know that Aussie Med Ed is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.